Good morning, good afternoon, and good evening, everyone. Thank you for joining us from different parts of the world. My name is Yolande Andrews from NCOSA, and I'm very happy to welcome you to the NCOSA series of webinars hosted under the banner of the Amaqhawekazi Harm Reduction Project. NCOSA is a national networking organization working to build stronger, more equal, healthy, and safe communities, free from HIV, AIDS, TB, and gender-based violence. We do this by strengthening community systems, mobilizing and managing resources, facilitating networking and collaborations, and also by providing and enabling access to services and advocating, learning, and sharing collectively. This particular webinar is very close to NCOSA's heart and is very timely conversation that is very relevant to key populations, particularly because we are in Women's Month. Women who use drugs and the LGBTQI community often experience overlapping forms of marginalization. For instance, the queer female community who use drugs may face compounded stigma, making it harder to access legal services and post-violence care services. So what we are looking at is we are calling for gender-sensitive, inclusive programming for queer women and women who use drugs who often remain invisible within broader substance use services. And therefore, this gender transformative programs need to be looking at, layered services that address stigma, trauma, mental health, and social exclusion. And we have a panel of amazing speakers. So we welcome you again, and we offer as well interpretation in French and in sign language. So you're welcome to go to the interpretation icon to access the languages that you would prefer. Before we move forward to our first speaker, let us welcome you to a video that was done with our partners, Ntlotleng and the Nova Health Institute, around women who use drugs and the struggles that they face in terms of gender-based violence and lack of harm reduction services.
I was a drug addict starting from 2012 until this year, 2024. I was injecting myself, I was using heroin. I didn't even have hope anymore in my life.
You know when you feel like you're not a human being, and you're treated like you're not a person or statistic?
Remember that women who use drugs are really discriminated against, and they go through so much trauma. You're seen as you're a mother, and everyone is expecting mothers to be perfect.
The life we live here on the streets, we get raped, like by people we know.
So communities need to support them, communities need to understand their journey, communities need to understand their choices, and communities need to understand that they are not different from an ordinary person who doesn't use drugs. So that you can hear the story behind, because we all have stories to share.
So once again, thank you, Ntlotleng and Nova, for showcasing the struggles, and someone that I'm very proud to be involved with and collaborated before with is Angela McBride from the South African People Who Use Drugs, SANPUD. Angela McBride is an executive director of the South African Network of People Who Use Drugs, is a woman with over 8 years of experience in harm reduction. She began as a peer educator for South Africa's first needle and syringe program and has since collaborated with various service delivery programs, organizations, and people who use drugs. McBride is actively involved in human rights and advocacy initiatives, as well as research and training on topics like safer drug use, overdose prevention, hepatitis, and general harm reduction. Welcome, Angela, and thank you for giving us your presentation on gender-based violence and femicide amongst women who use drugs. Over to you, Angela.
Thank you so much, Yolande, and thank you, everyone, for this opportunity. I'd like to spend some time today highlighting the work that has been done with incredible women across the country, in partnership with a lot of key stakeholders and role players that have really helped to shape and change and address the needs. We still have a long way to go, but we're in this together, and space like this are an amazing opportunity to start. So with that said, noting this first slide, I think a lot of people in this webinar are aware, at least have an idea of the experiences and how women who use drugs face increased stigmatization, vulnerability, and marginalization. And the research that we do have has shown that we as women are more susceptible to health-related and HIV, more so than our male counterparts. However, despite these increased risks, we as women who use drugs are underrepresented in the research and in research literature and within relevant services. We note that women who use drugs are at higher risk of violence and health issues. Socioeconomic status in combination with drug use and homelessness influences the treatment received from law enforcement and public health providers. Sexual assault, violence at the hands of partners, violence at the hands of law enforcement and the general population, as well as denial of healthcare services are all common themes. These experiences shape the way women who use drugs view ourselves, as well as view the perception or perceive the world as well as negatively affects their access to HIV and health treatment. However, working together as communities, service providers, and activists, we can address and push back on these harsh experiences that plague a community of women. Next slide, please. So to start off, I'd love to share a little bit around a UNODC needs assessment that took place in 2018, which supported consultations in 4 cities in South Africa, particularly Pretoria, Cape Town, Durban, and Johannesburg. And this was done to get a better understanding of the lived experiences of women who use drugs, as well as to assess the needs, the challenges, but also our suggestions on solutions as women who use drugs. This assessment was led by women who use drugs and consulted with women who use drugs, highlighting key elements like that which was raised by Fifi in the quotes above. I don't have a partner. I don't want a boyfriend. It's trouble. The men make the woman work for their drug habit, so I don't want to use my body to support another person's habit. GBV and exploitation experienced by women who use drugs are addressable with enough resources, and we can assist in addressing the needs, particularly by addressing needs like women-led networks, safe spaces for women, ablution facilities for women that are safe, psychosocial support and OAT, as well as sufficient harm reduction education, commodities, and interventions. The similarities between the provincial challenges and experiences of women who use drugs were evident, but the differences also shone through, showing us very clearly that there is no one size fits all. Services need to be community-centered, community-led, and advocacy efforts must include and be driven by people who use drugs. Noting this, feedback loops of findings are imperative when doing research and when engaging with our community. This gives us an opportunity to feedback and give input on the findings, but also to put the ball in the stakeholders' courts to say, where can you meet us? Where can we address this together? Lastly, along with further feedback loops, it is vital to continue to dig deeper and investigate further challenges, needs, and solutions. An example of this can be seen on our next slide, please. So speaking of which, when leaning on local experience, or when engaging with communities, we also need to lean on local experiences to highlight key challenges. As mentioned above, there is no one size fits all. So in 2019, HRI and SANPUD engaged in 2 focus group discussions to investigate the experiences of women who use drugs with access to harm reduction healthcare services, particularly in Durban. The participants were invited to share their experiences in two groups. The one group looked particularly at harm reduction and law enforcement experiences, and the second group talked around arrest and detention and prison, discussing such experiences of women use drugs, her health, safe for injecting and accessing harm reduction services. What is very noteworthy is despite a clear desire to achieve good health and practice harm reduction, these women were continually blocked from doing so by law enforcement ecosystems that see us and women who use drugs as undeserving of basic respect and dignity. In this particular research, we heard how law enforcement officers would prevent women from accessing justice and harm reduction services, and how they would enact harms on them directly through physical, sexual, and psychological abuse. However, there were also some positive stories. A few individual police officers were recognized as approaching women who use drugs with kindness, compassion, and decency. Significantly, the women made it clear to us that the staff in the harm reduction centers were always welcoming, bringing warmth, compassion, and kindness to them, reminding women that you're human before anything else. However, we must note that repetitive abuses experienced by women show that harm reduction interventions are not always taken seriously. And as a result, pushing back on these harms, arming women with information, skills, and standing up to these practices is an ongoing effort. I'd like to move on to the next slide and just highlight again the importance of partnerships and also that feedback loop as previously mentioned, because only with connections and relationships can we work together to address the needs. One of the examples was International Women's Day, where SANPUD worked with a number of centers like the Harm Reduction Center, Belhaven Harm Reduction Center, Sadiba Hope Medical Center, as well as Chapel Street Clinic, where we work together to provide STI screening, cervical cancer screening, pap smears, as well as information on cervical cancer, STIs, particularly focused on women who use drugs, as well as some like pretty commodities to go with it, because every now and then, and I think it depends on the person, but I know I feel a little bit better when I put some lipstick on or when I have that opportunity. So I think, again, that kind of just highlighted how we can all work together to address key elements and needs, such as basic healthcare, basic needs, as well as some compassionate care and safe spaces for women. Next slide, please. Again, as we noted in the SANPUD HRI focus groups, experiences are entrenched, and there is this entrenched expectation on women around foundational elements of barriers to harm reduction services. Examples of such include the expectation of being the primary caregiver, to always be accommodating, to always be subordinate to the needs of men. However, these experiences of stigma and entrenched expectations are particularly acute for women who use drugs when it comes to pregnancy and parenting. The proliferation of myths and half-truths, for example, related to fetal health and withdrawal, and the misinterpretation of data around pregnancy and drug use contributes to an environment where women are subjected to misinformation from healthcare providers and deterred from accessing services. The stigma created by these environments prevent healthcare professionals from engaging meaningfully with women who use drugs, and also disincentivizes women from having open conversations about drug use and pregnancy and parenting. And this can, of course, force women into riskier practices to conceal drug use and or pregnancy. However, in a pursuit to mitigate these experiences and these harmful experiences, Julie McDonnell, a consultant working for SANPUD, along with some incredible people from across the globe, decided to take up the challenge of capacitating and training healthcare professionals that engage with these vulnerable women. Thus, the development of pregnancy and substance use toolkit arose. And this toolkit, particularly for South African healthcare professionals, sensitizing them on how best to engage with pregnant people who use drugs. I also want to just highlight that Julie McDonald will be joining Nonhlanhla for a podcast on the 21st of August at 11 a.m. Please do join. She'll be sharing about this incredible toolkit, giving some further background. So I'm not going to go into any more detail. I'm going to use that as a bit of a teaser. And I'd like to say, next slide, please. In addition to sensitization of healthcare workers and addressing the direct needs, also something that we noted was the importance of arming women who use drugs with key things like defense and understanding of rights, as well as raising awareness of the harmful experiences. Here in particular, I want to share a bit about the FemAlive campaign, which is a SANPUD and run and supported by a number of other partners initiative, but particularly run by Shanae Roberts, who's currently not here at the moment. She's away. And her aim around this particularly was to highlight we don't want to sit in femicide anymore. We don't want to live in that world of femicide. We want to take back our power, take back our words and call Fem alive. So this is an advocacy initiative driven by women for women who use drugs, particularly in Cape Town. Fem Alive is a powerful advocacy initiative by SANPUD that places women who use drugs at the center of the fight against gender-based violence and systematic discrimination. Through high visibility events like the one that took place in November 2021, as well as the commemorative silent walk that took place in March 2023, particularly saying, I won't be silenced. FemAlive has mobilized communities, built solidarity, and directly linked awareness, empowerment, and practical resources. This was to ensure advocacy goes beyond words into action to protect the rights of women who use drugs, challenge stigma, and drive policy change. With that said, I'll move on to the last two slides. In particular, this is a list of all the resources. So for ease of access, as well as for more information, here are the links for the research that was done, as well as more information around the toolkit, as well as Shanae's FemAlive campaigns. For more information, you're also welcome to reach out to SANPUD. And we can maybe move on to the last slide. Thank you so much. So I'd like to wind down particularly with this by sharing a poem that was written by one of the incredible women who joined us for the UNODC SANPUD needs assessment that I spoke about right at the beginning. And Catherine Botha particularly wrote this, I think, as a reminder for all of us that it's always about the start. So getting started, the hardest job, it seems, is just to make a start. Even when desire is strong, this is always the toughest part. You put off things that should be done, you wrestle with fear and doubt, but the only way your ship comes in is once you send it out. The time to do this is always now. You can't have a doubting heart. So once the first has begun, the things that you thought you couldn't do have already been halfway done. Thank you very much for this opportunity. The last slide is obviously just an appreciation post for the communities that have been a part, the loved ones we have lost to the war on people who use drugs, as well as all the individuals and partners not particularly mentioned here, lovers, haters, and allies who have made it possible for us to be where we are today. Thank you.
Thank you so much, Angela. I mean, I think you closed it up beautifully with that video. Let's not lose your video for a second. We will have to see your face as we go into the Q&A section. I do know that we are pressed for time, so I am just looking to see if there's any particular hands so that we can give people an opportunity to engage. But also, I do encourage you to really reach out to SANPUD. There are representatives in a number of provinces. The people who use drugs subsector is growing and expanding, and will be strengthened into a sector hopefully very, very soon under civil society. And we need more voices to talk for people who use drugs, or to raise support for people who use drugs, but particularly for women who use drugs. So I am, thanks Angela for putting your information in the chat. I don't see any hands, but if you don't mind unmuting, Angela, I got two particular questions if you don't mind. So the one particular question that I have is around, I'm hearing you talk about harm reduction. A lot of people don't perhaps know about harm reduction, so they're welcome to look at SANPUD's website, NCOSA's website as well, the UNODC's website to get more understanding. But particularly, I want to understand the link that you see in terms of access and expansion of harm reduction services, so your needles and syringes, psychosocial support, peer education, opiate substitution therapy, etc. How is that link to the reduction, to gender-based violence and femicide experienced by women who use drugs? Is there a link?
Thanks so much, Yolanda, and I love that question because I really feel like it is one of those brain teasers. I think, particularly if we look at creating a safe space for women and people of the high-risk community, not to say that men are not, but I do know that being able to access someone to talk to, whether that is a social worker, whether that is a fellow community member, to be able to debrief, will always help to reduce, maybe not the experience, but at least arm the woman and strengthen the woman enough to feel safe, to debrief and say, this is what's going on for me, because it all starts with that. But the starting point is possibly the needle. The starting point is possibly the methadone. So we can't separate the two. When there's harm reduction, we look at harm reduction as a holistic thing, reducing the harms experienced from homelessness, reducing the harms experienced from GBV. And we can only do this by introducing and upping the current services that we have, because the services we have are beautiful. I know the programs that are implementing the needle syringe program, that are implementing the OAT programs, that are implementing, any harm reduction program in South Africa. It's such an incredible, admirable space. And by opening that door and saying, hi, how are you? Here's a needle. Do you need is there anything else you need? Do you need some sanitary pads? Do you need some commodities? Do you want to have a shower? Being able to do that is such a step towards change. We can't, I wish we could just say, come, here's shelter, here's a safe space, but unfortunately we're not at that. But that's the important thing about scale up, is that info, that famous saying of how do you eat an elephant, one bite at a time. How do you address GBV? Pieces at a time. Give us a safe space to talk, give us a safe space to shower, look after ourselves, and give us the commodities that are needed. And the only way we can do that is by scaling up harm reduction, current services, but also into outlying areas that may not have anything right now. We've got to, we should be proud of what we've done and achieved in these few years since harm reduction was introduced. So it can only go up from here as long as there is political will, buy-in, and resources available. I hope that answers.
Well, Angela, that's an amazing thing. And just to reflect again, we're talking harm reduction services only in 13 districts of South Africa. So there's definitely a massive gap in terms of that. And that obviously means a push to female empowerment if we expand into other districts. Last question for you, Angela, because I know you pressed. But the last question is, talk to me a little bit about how does criminalization of drugs, how does it affect a woman who uses drugs accessing Tutuzela centers, accessing post-violence care if they are, being victimized in terms of sexual assault? How does that affect their access?
Brilliant question. I think the easiest, and it's also a multifaceted question. However, I think the pinpoint here is the fear of being arrested, the fear of being arrested either for drugs or for commodities, and the stigma associated. Once we take criminalization out of the discussion, we're able to refocus onto health and well-being. It's the whole concept of taking funding away from criminalization and moving it towards interventions, whatever those interventions may be, whether it is psychosocial support, whether it is methadone, whether it's needle syringes. So that money that is being spent on, prisons and incarceration and arrests, all of that can be tunneled and funneled into supportive initiatives rather than punishing ones. And I think we can't take away of the fear. We can't take away of the stigma that is associated with drug use. Anything that is criminalized at the moment, even with sex work, it impacts direct service access because of the stigma. I'm lucky enough that I can go to a harm reduction center because there is one nearby me. However, someone else in a district, like you said, Yolanda, there's only 13 districts. Anyone else in another district who doesn't have access to a harm reduction center, they're not able to go there. They have to go to a public clinic, disclose their drug use, disclose the issues, and that brings stigma. If we can take away criminalization, it's still going to be a fight. It's still going to be a lot of work around sensitization, a lot of work around educating clinics and service providers, but it's a start, because you can start by saying you can't judge someone for body autonomy. And I think as well, it kind of takes away the harms. I think you spoke about it as well in the slideshow, is a lot. There are some really not great experiences had by law enforcement. I'm not throwing anyone under the bus, but it does remove that element. It removes the elements of private security harassing communities. It takes away law enforcement being able to exploit, take bribes, sexual assault, even physical assault, takes those elements out, and it says, no, that energy needs to be put onto important things like creating a safe and supportive environment for the community. Hope that answers.
Thank you so much, Angela. That is amazing. And let's just also be quite aware that when we talk about criminalization, we're also referring to the criminalization of sex workers who fear accessing services, especially when they've been victimized, because of the criminalization. So when we talk criminalization or decriminalization, we need to look at all aspects. And so thank you so much, Angela. God bless you, and lots of love and support towards SANPUD and the efforts that you are making to advocate, not only for people who use drugs, but particularly for women who use drugs. So thank you so much for your time.
Thank you so much.
Okay, so we'll move on now, because I think Angela has put it really into perspective about the role of criminalization, but also particularly the role of stigma and discrimination and how it affects the queer community in terms of accessing post-violence care services. So we'll move on now to a short video, and this video was done in partnership with Gay Umbrella, but also in partnership with Parenting Families and Friends of South Africa queer communities.
South Africa is a very progressive country in terms of the law. However, there's a huge gap between the laws themselves and the attitudes and perceptions of people.
Our constitution looks great on paperwork, but in reality, it's not practical.
Any mental health assistance, we avoid that a lot. We don't speak about our problems. It's bred in a cyclone of toxicity. I started volunteering for the mayor's office because I did see the gap. I myself have had or have experienced multiple rapes or hate crimes.
Because the street guy they do and then they just kill you.
This thing ya hore ha ka tlameha ho kena kereke e santsane honna e santsane e setse ka baka la hore nthwene no ke mademona honna.
We find out that human rights violations happens every single day. Gay Umbrella is an organization that advocates for the rights of LGBTQI people in the Northwest. We are trying to make sure that services for the LGBTQI community in South Africa is available. How do we build an inclusive space where we support each other, we are not working against each other? Sensitization is a continuous thing. If we are going to be speaking to parents, we make sure that we bring just parents to the space. We try and make it more focused on who is there. It could be a safe space, it could be a dialogue, it could be a training, it could be a workshop.
Working with parents and families is not easy. It's a complex thing. You need to have strategies that are very cognizant of where parents come from. There's a difference of calling a person out and calling a person in. PIFSEC right now has more than 10,000 members of parents who are saying, we want to learn, we want to advocate. We have members of churches who go to churches who are very religious, but they can go into a church and say, please include LGBTIQ plus issues in our program.
Ho fihla nako ele ya hore o mong ba o kgesitseng ha mmoho le batswadi ba hao hore no ngwana no na le moya o mobe e ntho tse kaofela ka fumana hore no this thing e phela ka re ho nna ke na le modimo ka rona ke na le moya ka rona o modimo a la mbutselela gona ka honna o ntse go phela ka honna ho molemo hore ke tswele pele ka ntwenana because ke leto le le reng ntse ke le ho lona lena la hore le nna ka tsatsi le leng ke batla go bona ke eme ka pela setšhaba ke ba ruta empa ke sa ba ruti ka go ba tlosa tseleng e le reng ba ho yona ya bo modimo.
We are encouraging parents to allow themselves to be first-timers, begin to learn new things that they've never learned.
We are LGBTIAQ+ and we are alive!
I do see hope and I see light at the end of the tunnel. We won't see the change now. We will see the change that we are currently advocating for. We will see it in years to come within our children or our children's children. For me, I feel we are in the right direction. We are gradually getting there.
From today, we are learning, and we don't want to end here. We want to take it to the spaces that we occupy.
I'm still looking and longing for us to press with continuation, frequency, consistency and frequency. That's the only way how we'll end up reconditioning the minds. Because a once off is a light bulb, you know, but if we don't maintain it, then it dims again.
Start believing in yourself, start loving yourself. It's a jaka unse. Nobody can respect you or say respect you.
There's once again an appreciation to our partners, Gay Umbrella, and parenting friends and families of South African queers for giving us insight, even if it was just a moment, of the struggles and the human rights violations that are experienced by the queer community. I take a moment now to introduce you to an icon. We have the wonderful voice of Nonhlanhla Mkhize from the Lesbian community and Gay Community and Health Center. She's a health rights and public health advocate, volunteering with children, youth, and women, organizations and campaign activities in South Africa and in Africa, providing technical advice and support. She remains committed to promoting and defending people's rights to equality, dignity, freedom, regardless of race, ethnicity, age, sex, gender, sexual orientation, education, health, disability, and economic status. So I want to once again welcome from the Lesbian and Gay Community and Health Center, Nonhlanhla Mkhize.
Thank you so much to the host for unmuting me for a moment there. I thought of being silenced. Colleagues, good afternoon, and thank you, Team Nakosa, and of course, colleagues around the table for the invitation to be part of this very important conversation. Amaqhawekazi Harm Reduction webinar series, or at least as part of the webinar series. So colleagues at NACOSA had invited us to sort of share lessons as they relate in this context to the gaps that we have insofar as our programs relating to gender-based violence and femicide targeted at lesbian, gay, bisexual, transgender communities. But I think more so in line with the earlier speaker, the intersectionalities in our context as they are affecting lesbian, bisexual and transgender women in particular. So I want to appreciate the video that we've already had a chance to look at because it really resonates with some of the learnings that one would want to speak to in the next few slides. So I'm going to attempt to highlight just a few achievements that we've made as a country as it relates to us fighting against gender-based violence as it affects LGBTI communities, but also highlight a few lessons that we've learned in our work, primarily from a lesbian and gay community and health center perspective, but colleagues might be aware that my work also is such that one works with the LGBTI sector across the country. So which means I would also draw from those. If colleagues on call could assist me with the presentation. I'm not seeing it loaded on my side, but I'm skipping to the second page as it introduces us to the premise of our conversation, which for me stems from quoting, of course, from the South African Constitution. And that's in particular chapter 2, when we're looking at the Bill of Rights, and within that, the Equality Clause, section 9, and just to draw on the two subsections 1 and 3, that you have the Constitution in that particular clause refer us to, where number 1, it's really painting the primary principles of non-discrimination. And of course, the first one being that everyone is equal before the law and has the right to equal protection and benefit of the law. And of course, subsection 3, which is linked to 2, is the one that very much relates to the fact that neither the state nor any individual that is a citizen or a person, a resident of the country, may unfairly discriminate directly or indirectly against anyone. And it provides a variety of grounds within which this non-discrimination or this unfair discrimination is therefore being reflected on. And amongst those, you've got gender, you've got sex, you've got sexual orientation, but you've got age, disability, religion, ethnicity, marital status. And of course, for our conversation, that becomes important when you're looking at the intersectionalities, insofar as our identities as people that are lesbian, gay, bisexual, transgender, or even intersex. The next slide, I'm not so sure if colleagues are able to see it because it is not reflecting on my side. So I'm just going ahead. All right. But when you get to that third slide, you'd then start seeing some of the definitions that some of us work with in our different work, but also a type of imagery that we've sort of gotten ourselves accustomed to. We do not call that little person running on the side the gingerbread man anymore, but we refer to them as a gingerbread person. A lot to do with language that has had to change to create an enabling environment for our equitable fight for against gender-based violence as it relates into our context, LGBTI. But simply put, the first slide that you would have been exposed to that had the topic, but also the name, gave you that rainbow flag that also had intertwined with it what we refer to as the trans flag, but also as the sexual characteristics flag that also had the yellow and the purple in circle. Now, when you look at the first three definitions that have been shared with you, speaking on issues around being gay, being lesbian, being bisexual, but also jumping on to then the blue and pink, when you are looking at the concept of being transgender individual that may have been at birth assigned a particular sexual identity, and then as they grow up, they identify, discover, and embrace their full identity insofar as the category that they identify with. In this case, being if it means one was assigned male at birth, perhaps in their growth, they discovered that no, actually, I'm a fine young man, and of course, that they embrace their full identity. Now, those are the processes that we go through, and in at this context in time, we've tried to put them simply insofar as definitions are concerned in that manner, and of course, as it relates to intersexuality, and of course, there you'd understand as well that in our different spaces of work, we have been people that are very careful in how we talk about diversity within that context as well, noting the level of diversity that exists in our communities insofar as how one is perhaps identified as intersex, insofar as looking at their sexual characteristics. I'm not going to go into it too much because we could discuss that in a variety of other spaces, apart from you all having been exposed into those definitions. But I think the highlight about that is the discourse that we find ourselves being exposed to as individuals, our bodies, our minds, and our own experiences, but also the communities that are expected to appreciate and accept and work with the different diversities that they are finding in the context of, as indicated, where our Constitution puts us of non-discrimination. Looking at where we've been insofar as not just the context of gender-based violence, but also hate crimes and fighting non-discrimination. The next slide basically paints the work that has happened between government, civil society, and business, but also that has happened just amongst ourselves as civil society, from the concept of us having structures in our community that are like the provincial councils on AIDS, that are focusing on joint or collaborative work as it relates to a response. So a multidisciplinary approach in dealing with social ills, in fighting violence, in fighting injustice, in addressing harm that we are being exposed to. So what that does for you is just paint some of the achievements that we've had over time, from the concept of launching the task teams on hate crimes, but also looking at the inclusion of individuals identified as LGBTI in the country's national strategic frameworks that respond to certain either epidemics. And of course, in this context, we've looked at HIV as one epidemic, we've looked at hate crime as another epidemic, and of course, gender-based violence and femicide as another epidemic. And of course, towards the end of that slide, it starts looking at even some of the training that has had to be prioritized, looking at colleagues within the National Prosecuting Authority, how to prepare our prosecutors and our magistrates and even our judges, how to prepare and engage with our South African police services, but also insofar as preparing guidelines, insofar as to how to work with diversity within our schooling environments, Department of Education, both basic education and at higher or tertiary levels. But even more so, a specific training on the judiciary, so that what happens in our courts as it relates to what sets jurisprudence for our own experiences on the ground is quite important, that the cases that they preside over and the decisions that they make really make a landscape or lead to a landscape that is a little bit more rainbow, if I could use that as a symbol of diversity, appreciating diversity, recognizing that we are not necessarily experiencing gender-based violence or even hate crime or even hate speech the same, and that there's a level of paying attention to the different minorities. I think the next slide then for me starts looking at where some of the lessons have been for us that, with all of this wonderful work that organizations are doing on the ground, that individual activists are doing, but also colleagues within the academic and research field embarked on, what seems to be the gap, and it's the gap that is dealing with the individual. If you look at how we've succeeded as a country between 1996 with the Constitution coming to being in 2006 when we had our right to same-sex marriages, and how from 2007 we see a surge insofar as hate crime-related cases, it gives you a sense that there's a shift that happened insofar as the social ills are concerned, but also social and general community understanding of diversity. But it did not just affect the communities themselves, it affected us as individuals whose lived experience, but also identity is lesbian, gay, bisexual, transgender, and intersex. I've used the concept of fear to say that we found ourselves in a space where just when we were excited about the progress in the country, we found ourselves in a fearful space of being able to come out, fearful space of being able to associate and even use language, expressions, dress, and occupy spaces that would make us feel as part and parcel of the general society. It's at one moment we find ourselves having rights entrenched insofar as being able to have children, raise children, have families, get married, have access to employment, education, but at the same time, you are finding ourselves in spaces where all of that does not necessarily take away that fear. And why that fear? Because as you see the surge from 2004, even more so 2007, it has a lot to do with what we've been subject to. And that's the hate speech, and that's the hate crime, but even more so gender-based violence. But that gender-based violence, and I think this is important for our conversation as well, is not just targeted towards us. What you see because of our own fears and therefore the impact of that in our own concept of mental wellness is how we ourselves have become agents for destruction, where we've also made others be fearful in our own families, in our own relationships, and even our own selves, insofar as being able to create those enabling spaces for people to able to thrive. So you see three negative experiences that one reflects on, the impact that this fear has insofar as our thinking, how we perform, how we act in our different spaces in life, but also our ability to grow and thrive in our different spaces, whether in relationships, whether at work, whether at school, and so on. Because gender-based violence is not only limited in domestic spaces, but also when it comes to our relationships with ourselves, with our immediate families and partners, but also with everybody else that we work with. The fears that have come from constant exposure to exclusion, to bullying, to harassment, extreme cases of violence that others have experienced, and even loss of life beyond loss of family, loss of home, loss of job, loss of access to education, or even a social life. But mostly for others, it's been the loss of life. But it's what has this done to us in our different spaces, the fear that it has created. Of course, the next slide would indicate that what we say a lot in our trainings is the need for respect of diversity. But it's important to get there when we have not even alleviated what was there in the later slide, which would allow us to even embrace the various diversities in our communities, more so as it relates to transgender communities, because being lesbian, being bisexual, being gay, we seem to be in spaces where there's almost a level of understanding, even though it's not complete, but it's even more complicated once you start explaining one's transgender identity, non-conforming identity, non-binary identity, or even sexuality. And I guess in the last two slides, one wants to reflect on the need also part and parcel of that fear and dealing with how in our different trainings, in our different community dialogues, in our own conversation spaces, we invest a little bit more in research. I noted there the work that was done by colleagues within the other foundation insofar as their progressive truths. And I was quite taken aback by one of the statements within that it speaks to the majority of South Africans being a people that who perhaps when it comes to LGBTI understand the sense of human rights, that we are all equal, that all of us are human, have a right to life, and probably need to be respected in our diversity. But for some strange reason, when it comes to understanding the concept of same-sex relations or transgender relations, finding all of us morally wrong. And the question is how we work with that insofar as education, training, but also creating a social cohesion within our communities that is such that it allows us to change the mindset. And I guess the last one for me, insofar as that is concerned as well, is as we do that, we should be people that do not look away in a context of where violence is being experienced or where violence is being perpetrated. And I want to end on that note. Thank you, colleagues. The last slides just give you a little bit about the organization. Thank you, colleagues at NACOSA.
Thanks so much. Please continue to have your camera on as we open it up for questions. I know you wanted to dodge me there, but I caught you. So let me just see for like 1 second if there's any particular question. Norma's got a point. I don't know if Norma wants to articulate it, but Norma's made a point in terms of her question to Gay Umbrella. Unfortunately, Gay Umbrella I don't think is here, but what I have done is that I have actually put Gay Umbrella's contact details in the chat box. So I do encourage people to reach out to Gay Umbrella for their support. But maybe just check if there's any particular questions for our speaker right now. I'll give a minute to see if there's any hands. Okay, so this is like I see the camera's off, but I'm gonna ask you to put the camera back on. And Nonhlanhla, if we can maybe just go into a conversation about it's something that's very delicate, perhaps. And we want to be respectful to this because we understand we are in an environment of restricted funding. But I think that, you know, when we talk about key populations, usually there's a reference to certain groups in terms of key population programming. And in most cases, it does avoid or excludes a lot of, you know, aspects of the queer community, particularly the lesbian, the queer female. So I just wanted to gauge your, you know, your questions when we talk about programming gaps. We're really talking also about resource mobilization gaps. So in your opinion, you know, what is the concerns that you think there are around, you know, the exclusion of all aspects of the queer community when it comes to key population programming?
Sure. I think as it related to the concept of experience here, it's if we, from a programmatic perspective, understand what our clientele or what our communities are battling with, it then puts it upon us to make sure that in our programming, we've been as inclusive and as comprehensive as we could possibly be. Right now, if you look at how our programming insofar as the response to HIV, TB, and STI, it has been very focused on men who have sex with men and transgender women to the detriment of gay men, lesbian women, and even trans men. But it has a lot to do with who is behind the research, who is behind the program design, and who's behind the setting of those objectives and their understanding of the exposure and the experience of the individual service user. And therefore, who are we excluding in the process? If you look at the work that has been done in that and how we are trying to push the envelope and say, but we can't keep focusing on just men who have sex with men and transgender women when you're talking about exposure because of now we're talking the language of intersectionalities. We are talking a language of comprehensive healthcare. So if we are talking about comprehensive and or holistic approaches, human rights-based approaches, and we've got work, for instance, colleagues within Gay Umbrella and many others have done insofar as documenting human rights violation. When we go and access services, who gets violated based on what? So from how I look to how I dress to how I express myself just at the gate, before I've even accessed administration block, how have I been treated? Because for me as the service user, that's where my fear comes insofar as accessing the service. So if the mindset can change in understanding who the target market is, then there's a lot that we will see changing insofar as how programs have been designed for a far more comprehensive and holistic uptake.
Yeah. And just one last question while I still have you. I mean, I think the reality is that we do a lot of work as NCOSA and yourself and a few other partners around post-violence care, but we are seeing a serious gap. I know this conversation is about the queer community, but if we look at post-violence care services, men are also victims or survivors of sexual assault. You know, men also experience domestic violence, but we're not seeing them necessarily come forward. And is that a programming issue that we have where we maybe are not as sensitized or our resources are not, aimed towards it? But I see a gap in terms of, if you're talking about HIV prevention, people's access to pre-exposure prophylaxis is important, but we're not necessarily seeing male survivors accessing it. Your opinion?
I think once again, it goes to who was at the program design and what was their focus. And if it means that it's the understanding is that it's been deduced from research, the question then becomes who was behind the research, who drafted the research questionnaires, and how did they target the population that therefore fed the information that fed the program design and therefore the implementation. Because we can't anymore say it's a funding issue. I'm of the belief and experience where mine is we can't use funding as an excuse. In my work where I am, just as much as anyone else that is working with individuals that are sex workers, individuals that are drug users, how are we thinking holistically about a person that is a drug user? How are we thinking holistically about a person that is a lesbian? Could they potentially be somebody who's a sex worker, who's a drug user, who's a survivor of violence? How in our programming have we structured from our training, even the language we use, the examples that we apply when we train others and when we train internally, that it is such that it is broad and inclusive and it is mindful of in one person, you can have so many interlinking issues. And the same goes when we talk about men. A lot of our language and materials, when it talks about sex positive experiences to do with engaging in sexual activities and preventing diseases within that space, you'd realize that it tends to focus on condoms for certain populations, and it would look at female condoms as though it's a responsibility of the woman to carry. So it's until we free ourselves from that linear way of thinking or that very boxed way of thinking, then we'll probably start seeing more and more people come forward to access services. Very much what we've seen with the adolescent and young people's programs, and what you're seeing when it comes to specific efforts now being done to rope in men into facilities, because it's not having a particular identity of a man. The images on our TV, the images that are being used on our materials are not giving you a particular identity of a man. So the more we do that, the more, even when it comes to gender-based violence and men that are survivors, that it opens up space for them to come forward and speak their truth or to their own experiences.
And thank you again for being a voice in the struggle. I think that it's important that we keep ourselves open-minded, that this is a much broader conversation and it needs more input from others to inform correct research, to inform correct programming and resource mobilization. So thank you again, Nonhlanhla, for your time. And we'll move on now to our next speaker. But please note, there's a comment for you, Nonhlanhla, in terms of your availability for training. So you see, Always good to say yes to me when I say please be part of my webinar. We have the next speaker that is joining us, and Dr. Mabena, Mabena is a force to be reckoned with in terms of GBV, particularly around her technical expertise and leadership that has been provided in several funding opportunities, as well as in terms of programming. Dr. Nonhlanhla Mabena is a South African public health clinician, academic and social justice activist dedicated to ensuring marginalized women have access to quality primary health care. With extensive qualifications, she serves as a GBV technical specialist and leader, focusing on empowering healthcare workers to support gender-based violence survivors. Through her organization, Open House Initiative, Dr. Mabena also provides psychosocial support to young queer females, embodying her holistic approach to healing and transformation. And we're very fortunate to have her perspective and technical expertise around decentralizing post-violence care for key populations. Dr. Mabena, welcome, and over to you.
Thank you. So good afternoon to you all. Thank you so much for the opportunity to be on this webinar. And Yolande, thank you so much for giving me the opportunity to still have my head somewhere there in the spaces that I used to work with. So my conversation today with all of you is really about talking about lesbians or queer people, if I can put it that way, talking about violence, and also focusing a little bit on the proximity to and possibly access to post-violence care services. These three topics that I'm separating for you are actually my deep passions, and I can speak for an hour on each of the topics. So I have the challenge of speaking really just in 15 minutes, combining all of the concepts, so that at least I convey some congruent messages to you and you can learn something from it. If we move to the next slide, what is the problem? I think it's very important to first locate ourselves into what problem are we dealing with, who is the problem affecting, and then talk about solutions, possible solutions of how do we now mitigate for this problem, and what solutions are reasonable and feasible for us to implement. I think the problem here that we are talking about today is violence, especially against people who are marginalized, who are vulnerable within community because of their identity. And I think I have to point out at this point that violence, when we talk about violence, and I talk about violence on purpose and not say GBV, because violence is violence, whether it is happening on the basis of gender, on the basis of sexual orientation, on the basis of hate, or whatever it is, but violence is violence. But violence is not only just physical violence or sexual violence. Those are the extreme cases, the extreme ends of the spectrum of the harm that we cause to each other as humanity. We have to also start looking at violence more holistically, in terms of it being rejection is a form of violence. It harms people, it causes people harm, it causes people not to be able to self-actualize and thrive. We also look at neglect, and neglect by people who you live with, people who you depend on, or even systemic neglect when certain identities do not find it feasible to access certain services because the system does not provide that kind of service for, or does not make that service accessible to those people who need it. And I loved the question that Yolande asked to MC just now about men who are experiencing violence and their proximity to accessing services. It shows us again that we are really so focused on identity politics. We are so concerned about this label and that label and that label, and we are not concentrating on the actual problem, or the need, which would be access to services because somebody has been harmed or has experienced violence. If we start moving our lens a little bit away from identity politics and we start talking more about needs and our politics become needs-based, then we will cut out this whole thing that certain people are not catered for or certain people are favored over certain interventions, because now we are talking about a need and not identity labels. But having said that, obviously more vulnerable people like queer people remain even more vulnerable to experiencing harm or violence and trauma because of their status within society. And MC also spoke about the fact that when we talk about violence, we're not only talking about violence that happens to us as queer people, but we're also talking about the violence that we exhibit towards each other as LGBT people, as people in a relationship. And within the ecosystem of provision of services, for instance, I've worked quite a bit in the different Tutuzela care centers and trained healthcare workers around the whole country. There is very little knowledge that healthcare providers have on managing survivors of sexual violence that was perpetrated. If the survivor was a woman, for instance, if the violence was perpetrated by another female person, some healthcare providers just simply don't know how to deal with those cases, and they just treat them based on their heteronormative protocols that they have, but not really meeting the needs of those queer people who have been victimized by people of the same body. So we also look at survivors facing a lot of stigma, discrimination, and secondary victimization. This we often underplay because we assume that services are there and services are accessible to people. I mean, there are clinics everywhere, there are police stations everywhere, so we assume that services are actually available for people. But what we don't consider is the amount of harm that they experience when they go into those spaces. First, they have to come out of, disclose their sexual orientation or gender identity to total strangers, and then also come out disclosing a very harmful event that may have happened to them, be it a rape or a physical assault to them. So how the service providers respond to people who are coming in to try and access services can also be really harmful and victimizing for those people who are coming in for services. So we shouldn't only look at the fact that services are there, but we should also interrogate the quality of services, the value-based services that are being offered to those people so that the harm is decreased and we are not putting people in more danger. And then the issue of safe spaces. Safe spaces, we traditionally see them as spaces that have been provided by NGOs or community organizations where usually survivors would go and get psychosocial support and all of those things. But if we really think about it, as what makes a safe space, it's really about people feeling physically safe, people feeling psychologically and emotionally safe. What does that mean? It means people feel that in this space, I can speak my truth and don't fear to be judged. I can be myself and I will not be criticized for who I am. I can be cared for, I can be loved, I can be respected, I can be treated with dignity. That is what psychological safety means. And if we look at this explanation of safe spaces that I just gave you, we would then realize that actually safe spaces should not only be those spaces that have been labeled as safe spaces by NGOs and all these other organizations who try by all means to create these spaces, but in fact, we should be demanding that all service points that serve communities should inherently become safe spaces. If there's a clinic that is seeing people, if there's a police station, if there's a church, if there's a school, whatever it is where people commune and go to for different reasons, we should be investing in making those places safe spaces so that as people are going, to get their medical care, to open a case or to go to church or whatever, they are feeling psychologically and physically safe enough to be able to disclose and then therefore get the necessary help that they get. And so obviously it means that we need to do a lot more work in making sure that these spaces are psychologically safe. Because like we said, a lot of secondary victimization happens in those kind of spaces. And this really speaks to working with service providers, working with people actually, to make them more competent or humble to work with other human beings without judging them. It's not even about training necessary, but it's just reinstilling the values that we live by, so that people who do come for our services feel respected, feel that we are treating them with dignity, we are caring for them, we have their best interests at heart, etc. So we'll move to the next slide because I can't speak forever if I don't change my slides. So this slide talks a little bit about drivers of gender-based violence and homophobic violence. And I think it's important at this point, since I haven't heard any of the speakers talk a bit about this, it's important to be clear in language, right? We have to locate our language and our use of words correctly. We know that a lot of people still refer to homophobic violence or homophobic rape, transphobic rape as corrective rape. And I hope if there's one thing that you can take away from my input today is that language matters and we don't use the terms corrective rape, because what that does, there's nothing corrective about this heinous violence that's often dished out to people who are vulnerable. There's nothing corrective about it. So if we call something in that name, we almost sort of giving it permission to exist and saying it is a valid kind of thing. So we don't use the word corrective rape. Please, if you had that word in your vocabulary, please Control Alt Delete, and let's call a spade a spade. It is violence based on the basis of sexual orientation or gender identity, homophobic or transphobic violence. I'm not going to read through or talk about the different drivers that you see on screen, but I think we can summarize them really nicely by saying that the drivers of violence are usually hate or even fear. Because when people are fearful of their own positions in society, it almost becomes easier for them to be violent towards, especially those who they deem are less powerful than they are. So we should always keep these drivers in mind, because if we are saying we want to end violence against people, against human beings, we have to be looking at each of these drivers and see how do we mitigate these drivers. They are not causes, right? They're not causes of the violence, because the violence is meted by this person who is violent. But the circumstances may fuel the fire if we are not dealing with the circumstances and the drivers as we should. Next slide, please. So we have to now reflect a little bit. So we spoke about what the problem is, what we think the problem is, and now why do we think the problem is the problem that it is? And I guess it's got a lot to do with our own judgments as human beings. We've got prejudices, we've got biases, and we often bring those prejudices and biases within our professional spaces, which then completely invalidates the care that we are supposedly giving to these people, because we are now no longer looking at this person as somebody who's coming to me for care as a human being, but I am now judging this person based on my own personal prejudices and biases. So we have to do some work there, because clearly if prejudice and bias affects the quality of services, then it means there are interventions that we need to met against that. Then the other issue is the issue of centralizing services. What does this really mean? I think everybody, when we talk about post-violence care, gender-based violence, rape, all of these things, we often think of Tutuzela care centers, which are places, one-stop places where people can go and access post-violence care services in a holistic fashion. But we do know that we've got very few of those kind of facilities around the country. I think, there are less than 70 facilities in this population that is so big. And we do know, we keep admitting that gender-based violence is a pandemic, but the infrastructure to meet the needs of survivors doesn't match the burden of the problem. So we have to now start talking about how do we get services out there to people, where people live, where people do life, where people go for their normal primary healthcare activities and things like that. So decentralizing post-violence care becomes something that is important to talk about, because if you talk about somebody who's been raped or somebody who has been physically assaulted, what is there about a specialized service that cannot be done at a lower level facility or a PHC or a community health center? Mostly, it's usually the collection of evidence and possibly the completion of the J88 or the medical records. But I can also argue to say that actually might not necessarily be true, because clinicians who work in PHCs, in CHCs, there in the ground, also do complete J88s, because all common assault cases that come through those facilities, the clinicians there would have to see, would have to document all the injuries and, go to court if the need arises. But because a lot of people are so scared of going to court and all of this, it has become an excuse of why do we not decentralize post-violence care services, because of providers who are fearful of going to court. Again, we are not meeting the need of the survivor here. We are meeting the need of the provider who says they are uncomfortable to go to court. But if we were truly survivor-centered, we would be making sure that these services are actually available at the ground. And in actual fact, our regulations and laws and all of that do say that nobody should ever be turned away away from healthcare services, especially if it's an emergency. And we know sexual assault or sexual offenses, we consider them an emergency, a medical emergency, because we have to, give people time-sensitive medication and treatment, which can easily be given at a lower level healthcare facility. Then if people are not comfortable with, collecting the evidence and all of that, and the person needs to be referred higher on to a specialist facility, then all of that can happen after the initial containment, the initial medical care provided to the survivor, so that at least we're not continuously harming them, causing them secondary victimization, etc. MC spoke a lot about intersectionality, so I'm not really going to belabor that point again. But again, I think it brings us back to the point that and it's the pervasive nature of funding, I think, also, because we have disembodied a human being and just labeled them. It's a lesbian, it's a person who uses drugs, it's a person with disability, it's a sex worker, it's a this, it's a that. And our funding streams will then fund according to those labels, forgetting that this is actually one human being. One person can carry all of those labels. So therefore, our services and our programs should be responding to a human being and not be responding to the labels or the identities of that person only. So yeah, one of why all of this problem is also ongoing is again about psychological safety, not feeling that they can speak their truth, not feeling that they are going to get help without being judged, and therefore people don't end up going for those services. Next slide. So there are some pathways. So it's not all doom and gloom. There are some pathways that we can be looking into, so that we can start fixing these problems that we have identified and the reasons why these problems persist. And we've already spoken about the decentralization of post-violence care. to go into community levels. Often within our health system, we've got a cadre of staff called community health workers. And then even in certain provinces, in Gauteng, for instance, they even have what they call GBV brigades. So what this means, it means we actually have foot soldiers in communities, people who are already known in communities, people who are trusted in communities, people who know where people go to. So we've got the ideal people within our communities who are walking through communities already that we could be capacitating or empowering to be able to be a little bit more effective in case finding, case management, supporting, providing more psychosocial support and reintegration activities for survivors. So once we start using the entire ecosystem of the health system and not just focusing on what happens at a Tutuzela or a clinical forensic medicine clinic, then we will actually probably get more bang for our bucks because we've got more people who are able to become safe spaces, who are able to provide safe spaces for survivors to be able to access care. You know, and one of the other things is that a lot of people actually don't want to open cases. They don't want to go to a Tutuzela and be encouraged to open a case for safety reasons, for family reasons, for a whole lot of different reasons. So by decentralizing services, bringing them closer in communities, you're also opening up access to those who don't necessarily want to open a case or don't want to open a case now, at least, so that they don't miss the health benefits of getting help quickly, the medical care and the psychosocial and the counseling that is very crucial in setting the tone for the healing for that person. And then, of course, training of providers to be culturally humble. I actually prefer the word cultural humility more than cultural competency, because it's not a competency issue so much by, you know, you have to tick these boxes, you have to know what to say and all of that, but it's literally just being a human being who knows how to deal and listen to other human beings. That's essentially what we are calling for when we are talking about training providers on different vulnerabilities and things like that. And I actually can't wait for our programs to start moving away from the identity labels, as I've been saying, so that even our diversity, equity, and inclusion trainings should be exactly that: comprehensive, holistic, look at people as people, acknowledge and appreciate all people's differences, whether it's on ability, whether it's on race, whether it's on orientation or whatever it is, because we can't keep on working in these silos where we are just training people on LGBT issues. We still haven't done anything about them managing people who use drugs. We still haven't trained them on people who are sex workers. We still haven't trained them on how to treat people with disabilities with compassion and dignity. So if we bring our efforts together and do comprehensive diversity, equity, and inclusion programming and trainings, it will be much more beneficial. And, you know, even further down the line, we don't even have to concentrate so much on the trainings. We can start taking that training money back to the needs of these people who need these services, so that the money goes to address that. And then, of course, we need to integrate multi-sectoral services and approaches. It cannot be that post-violence care is an issue that only has to be dealt with by clinicians and social workers. No, it's a whole ecosystem of different service providers and support structures that need to come to the party so that we are providing holistic care. Traditional healers, you know, one passion area of mine is how do we integrate traditional healers who are in communities to also become another step of support for people who are experiencing certain kinds of harms, so that they can provide the counseling, you know, the psychosocial support on a more ongoing basis, because they're already there in communities where people live. And then, of course, we're talking about building safer spaces, and it's not building as in infrastructure, where we need to build, you know, brick and mortar kind of places, but we build them by renewing our intentions, renewing our values, so that we become safe spaces for people who come and disclose to us, or people who come to us and request a particular service, so that we have a plethora of safe spaces simply because of the people who are working in those spaces, and not just standalone places, which also then, perpetuate the siloed way of doing things. That's safe space over there, it's only for the LGBTQ people, or that one there, it's only for the sex workers, or, so if we start making the safe spaces integral part of the community, then we can also help in building relationships in that way. Next slide. So what can we do? And these are almost like take homes that we can do. Some we can try and implement a little bit more urgently, while others are going to be work in progress. I think we've spoken enough about labels and having to think differently and move away from serving labels, and moving towards serving each other as human beings. I think once we can start doing that, then we don't spend so much time on the identity politics, which are getting us nowhere, and we can actually start having conversations and plans on self-actualization, actualization, and thriving, which is actually what we want to do, and not just keep surviving and be seen. But I think the important thing here is if we also concentrate on people's needs, right? If we are needs driven and not identity driven, that solves a lot of our siloed problems as well. But the problem is we cannot know a person's needs if we don't know who they are. If we are still fighting to be seen, then it's very difficult for you to know what my needs are, because we are still arguing about whether you can see me or not. So we need to really move beyond that, so that we can get to the meat of things and meet each other's needs. And our needs are the same, really. We need protection, we need love, we need respect, we need resources, we need the same things as human beings. So our commonness is actually much more greater than the differences, which is perpetuated by the labels that we often give to each other. And then we also have to go back to our human values. I think capitalism has really just messed up a whole lot of things for us, and money is at the center of everything that we do. I mean, funding, we talk about funding now, we're talking about all of these things. But if we pivot a little bit and really make values the thing that we base everything that we do on, then it takes away the power that money holds. Yes, we will still need money. Yes, we will still use money, but the principle that feeds, that guides our interactions should be values based. And then, of course, we need to do a lot more work with policymakers. We need to do more work with healthcare workers. And when I say more work with healthcare workers, I also feel like we actually also need to do more healing work with healthcare workers and service providers, because people are hurt. We all experience trauma. We all experience violence. And people are hurt, people are triggered, people are, experience a whole lot of things. And if we are not creating the platforms for people to heal, then we will not get the quality services that we are eventually calling out for, because people are treating us from a place of pain and not a place of serving what we are doing. We've spoken about psychological safety, and I think I just want to focus on the last sentence there, which talks about the concept of doing things together. And I think the operative word there is together. It's about building relationships. It's about doing things together. It's about, stopping the silos and start talking to each other, knowing each other, so that we can understand each other's needs a little bit more. And once we realize the power of relationships, the power of doing things together, and then we will remove the whole concept of competition and, which organization is getting the funding, which one is not, all of these things. If we just pool our resources, I think our efforts will go way further than they would go if we are working as individuals. And I think, next slide, I think it might be the last slide, and it is. So thank you very much. I hope that the conversation was fruitful, and apologies. I've been having a dry mouth and I don't have a glass of water next to me, so struggled a bit, but thanks.
You did not struggle at all. In actual fact, I don't actually have questions, but just take homes from your messaging, if I may, just reiterate it. And I actually saw, I think it was perhaps Norma made a comment in the chat to say, if nothing else, she's taken away the power of language, and there's no such thing as corrective rape. In actual fact, a conversation I had with someone once was, it's not homophobic, it's a hate crime. It's an actual hate crime against the queer community. And so if nothing else, Norma has articulated what she's taking on with. So I'm elated by that. But I think some of the basic points that I've picked up on is that psychological safety, safe spaces, it is a community responsibility. It is a public responsibility. I think we do tend to turn around a little bit and say, government needs to resource this. What is the Department of Social Development doing? What is the Department of Health doing? What is the National Prosecuting Authority doing? But the reality, from what I'm understanding from you, we are champions ourselves as communities. So what are we doing to ensure psychological safety and safe spaces within our community? Am I getting you correct there, Doc Mabena?
Absolutely, yes, spot on. And remember, everything starts with self, and everything starts at home. And when we talk about safe spaces, and that's why I often like to say that safe spaces are people. They're not even buildings and things like that. If we take those principles of providing safe spaces within our own families, then what stops us from taking that very same thing to our workspaces? So yes, of course, the responsibility is all of us. All of us have to become the safe spaces for the people who are around us, so that the people around us are less harmed by how we respond to them and how we react to whatever they say.
Doc, I just want to maybe take one more take home that you've said is we need to stop being provider focused. We need to start being survivor focused in terms of our interventions. And that particularly resonates very, very deeply to me in terms of how we see a lot more focus is being placed on biomedical services, but not so much on the psychosocial support services that's required. So if nothing, I see people have said a lot of take homes, but that for me is particular as well. We need to be more survivor-centered, survivor-focused in our implementation. Okay. So Doc Mabena, thank you so much. I've actually put your details in the chat. There's quite a few colleagues here that seems to want to be able to reach out to you. And so thank you so much for your time. And just once again, being a strong advocate for people whose voices are not always heard. Their voices need to be heard. Their voices can be very loud, but they don't get opportunities for people to hear their loud voices. So thank you so much for being an advocate for them.
Thank you. Thank you so much for giving me the opportunity to come and do what I love. Thank you.
Thank you so much. We're moving now on to concluding our webinar. And just to say that we want to just express that the next webinar is also a very critical conversation that in most cases do not get any spotlight. And it should, because it's a priority for us. And here we're looking at the next webinar, which is on, the 2nd of September at 12 o'clock. We will be looking at the human rights violations experienced by the disabled community, particularly around, the programmatic gaps for key populations living with disabilities. So we invite you to register. The link will be in the chat to register for the next webinar, which will be the 2nd of September. So without further ado, colleagues, I hope that you have found incredible value as I have, that there are definitely many take-homes for us. And we need to realize the power of language in when we engage. We need to also learn that, the inclusion of key population is critical, especially when it comes to researching and program development, implementation and monitoring for all aspects of key populations and the queer community. So without further ado, I would like to thank our translators for Happy Clouds. We would also like to thank the technical team from Stack Active. Once again, just a heartfelt appreciation for Angela McBride from South African Network of People Who Use Drugs. We also had MC Mkhize from our Lesbian and Gay Health and Community Center, Dr. Mabena from Open House Initiative, and this would not be possible without the support from the VIV Healthcare Positive Action Program to make this Amaqhawekazi webinars possible. So thank you all for joining us, and we will be sending out the webinar recording as well as the presentations to all of you that have registered, and hope to see you on the 2nd of September for our next webinar on the disabilities, human rights violations experienced by the disabled community. Keep well.